Hi, my name is Kate Tipping and this is a presentation on the pathophysiology of asthma. Okay, we're going to talk about what is asthma, the symptoms, pathophysiology and clinical examination including OSCE tips, and then we're going to finish with multiple choice questions. We're also going to start with multiple choice questions. What do you already know? What does a short-acting beta-2 adrenergic receptor agonist do? Does it cause airway smooth muscles to relax, to constrict? Does it cause phlegm production? Does it cause increased coughing? And I've just put an example there of salbutamol, in case you ever get asked on placement for an example of a short-acting beta-2 adrenergic receptor agonist, and you can say, yeah, salbutamol. And the answer is causes airway smooth muscles to relax. Question 2. How is asthma usually diagnosed? So sputum testing, full blood count, spirometry and reversibility testing, and rectal examination. Bear in mind it's a respiratory disease, therefore tests should be respiratory related. Spirometry and reversibility testing is the answer. Definitely not a rectal examination for someone presenting with asthma symptoms. Okay. Question 3. What would be common symptoms for an asthma patient? So some of these symptoms on their own may be found in asthma, but what symptoms will be found together and what would be the most common likely symptoms? Bearing in mind that asthma is an obstructive airway disease, the same as chronic obstructive pulmonary disease. So the answer is wheezing, shortness of breath, chest tightness and coughing. Okay, right, on to what is asthma. So asthma is a common long-term inflammatory disease of the airways of the lungs. And according to Asthma UK, 5.4 million people in the UK receive treatment for asthma. So it is a really common condition, and it's likely that you've probably already come across it on placement, or you will definitely come across it on placement. And if you're going to be a GP, or you're in A&E, you're definitely going to see patients with asthma. And apparently I've read that it causes at least 40,000 deaths per year worldwide, and a death every 7 hours in the UK, which is quite substantial. It's characterised by variable and recurring symptoms. So the ones to look out for are chronic airway inflammation, airway hypersensitivity to a variety of stimuli, and airway obstruction. You can also get something known as adult asthma or late onset asthma. It's not usually triggered by allergens, and the exact cause is unknown. I did do some research into this, and there's not a conclusive theory on why this happens, but some research have said that it could be occupational exposure, so chemicals or other irritants. Smoking, and we all know how bad smoking is, so it's possibly this could cause late onset asthma, or even passive secondhand smoke. Obesity, and apparently female hormones, because women are actually more likely to be diagnosed with late onset asthma, or high levels of stress, which I think we've all got in medical school. Childhood asthma is usually related to atopy or atopy. Some children find that their asthma improves or completely disappears as they grow older, although in some cases has been known to come back once they're in adulthood. Atopic syndrome is a syndrome characterised by a tendency to be hyperallergic. So you'll find that people who have asthma also have eczema. They might have hay fever, as well as asthma. So these conditions tend to go hand in hand. Not always, nothing's a guarantee in medicine, but more often than not you may find that someone who's got asthma has eczema. So it's always worth to make sure when you're doing your history and your past medical history, you do you ask about other conditions. You always ask about skin as well. That's one a lot of people forget to ask about. Maybe in a review of systems you could ask about skin. And that might reveal that the patient has eczema. Okay, symptoms two most common symptoms of asthma are wheezing and coughing. They also complain of chest tightness, shortness of breath. Some patients describe an asthma attack as like breathing through a straw. And I have a friend who's asthmatic, and he says that the worst thing about asthma is when you have an asthma attack, it's very frightening because, basically, if you can't breathe, it's like suffocation. And that leads on to other things like fatigue, tachycardia, moist skin, and obviously anxiety, which is completely understandable. Episodes can occur a few times a day, a few times per week, and they're usually triggered by exercise, emotional upset, aspirin, cold air, cigarette smoke, and or allergens such as pollen, house dust mites, pets, mold, or a particular food. But I did learn today that you can actually get a Labradoodle that's hyperallergenic, so you can get that if you really want a dog and you're allergic to animals. Pathophysiology. So one of the typical aspects of airway inflammation of asthma is the infiltration of the airway wall by T helper type 2 cells. So evidence suggests that the Th2 cells basically play a triggering role in the recruitment of B cells, mast cells and eosinophils. And these B cells produce IgE antibodies. So high levels of eosinophils can cause inflammation in the airways, affecting the sinuses and nasal passages as well as the lower airways. Mast cells, they secrete histamine. They also secrete prostaglandin and leukotrienes, which then induce bronchoconstriction, mucus secretion, mucosal edema, which are all features of asthma. So I put together like this flow chart for you to have a look through. So basically you've got the patient coming into contact with an allergen, so for example smoke. The Th2 cells basically go bananas, and they activate like a humoral or antibody mediated immune response against smoke, which they see as this invader. So Th2 cells then activate interleukin-4. That then stimulates eosinophils, B lymphocytes. B lymphocytes start then producing IgE, which then cause mast cells to degranulate. And when mast cells degranulate, they release histamine, and histamine causes bronchoconstriction. Then you have interleukin-5. This also stimulates eosinophils. Now, eosinophils, always remember, it's the most characteristic cell that accumulates in asthma and allergic inflammation. So the more eosinophils you've got, then the more severe the asthma is. And IL-13, interleukin-13, stimulates mucus secretion. So you've got lots of inflammation, lots of bronchoconstriction, mucus secretion. You can see how it flows there. So this was up in one of our lectures. Basically, it just gives an overview of what's happening. You've got the lung at the top, the allergens, being inhaled, or they've come into contact with the allergen. And you have your Th2 cells there with the interleukins. You've got the mast cell. You've got release of eosinophils. So obviously all of this contributes to, there's a lot going on in asthma, and it's creating all these symptoms. But basically the Th2 cells are just going into overdrive. The clinical examination and history. Diagnosis is usually confirmed by spirometry with reversibility, and that involves performing spirometry before and after the patient has taken a medication. You'll usually give them an inhaler, so a beta-2 adrenergic agonist such as salbutamol. These inhalers will lead to relaxation of smooth muscle in the lung and open up the airway. So if a patient does have asthma, they will show an improvement in the spirometry after they've taken the inhaler. So before, be quite poor, take the inhaler, afterwards improvement, then you'll know it'll be asthma. You might also ask a patient to keep a peak expiratory flow rate diary, and diurnal variation may be noted. I'll talk about that in a bit more detail in a moment. But peak flow recording can be done at home by the patient, and it's just worth bearing in mind that usually this is an OSCE station they like to use, so demonstrating how to use a peak flow to a patient. It's easy to set up. It doesn't require a lot of equipment. It's not an invasive procedure. We don't have to ask patients to remove any items of clothing. It's simply you demonstrating how to use it. So make sure that you're up to date with how to do that. Geeky Medics has a brilliant video. You can also ask them to do a pheno test, so fractional exhaled nitric oxide, and also RAST tests, which demonstrates allergen-specific IgE. They're much rarer. Wikipedia does explain about both of those if you wanted to go into more detail, but usually, as I say, it's spirometry and reversibility. Oh, sorry. In an emergency, arterial blood gases may be taken because we need to show if the patient's got acidosis or they're alkalotic. So arterial blood gases are really good for showing that. Painful, but you know, it's worth it. If you get those results, then you can, you know what's happening with the patient. So OSCE tips. You may have seen this before. I've also put in the COPD lecture that I've done. I've said you may be asked. Highly likely you'll be asked to do this, to interpret basic spirometry results and also demonstrate peak flow. So please, if you do anything, go and watch that 2-minute video and just get used to the fact that they've got to get the best of 3, and you know how to use it and how the patient should sit, etc. Remember that asthma is an obstructive lung disease, same as COPD. So the FEV1 over FVC ratio will be decreased. Now, depending on what format they use, that'll either be less than 70% or less than 0.7. But remember, asthma, COPD, obstructive lung disease. You may go into a respiratory station in the OSCEs and they say, name 2 or 3 obstructive lung diseases, name 2 or 3 restrictive lung diseases. So make sure you know the difference and you can name. For everything that you do, every examination, always think of 3 things that it could be. So if you're specifically looking out for asthma, you would look for a wheeze on auscultation, but beware the silent chest, which means that in severe asthma, if there's no wheeze, it means there's insufficient airflow, and that's very dangerous. The patient with asthma will have difficulty breathing, they'll have shortness of breath. Check for signs of central cyanosis. So look the lips, look in the mouth, look under the tongue. Do they have a tremor? So the beta-2 agonists can cause a tremor. Ask them to hold their arms out straight and look for a tremor. Respiratory rates above 25 breaths per minute and heart rate above 110 beats per minute are regarded as significant signs in adults. So always when you're in the OSCE and you're doing a respiratory examination, check the pulse, check respiratory rates. If it's there, check blood pressure, but always check pulse and respiratory rates. Severe asthma, which requires hospital admission, is classified as peak expiratory flow below 50%, heart rate above 110 beats per minute, respiratory rate above 25 per minute, and the patient is unable to complete sentences in one breath. That may come up in an exam question, so be aware. Symptoms are worse at night in asthma and sometimes in the early morning and in a diurnal variation, and in response to exercise, allergen exposure and cold air. When taking a history from a patient with asthma or suspected asthma, remember to ask about allergies, and don't just ask about what they're allergic to, ask what happens during an allergic reaction. Ask about whether they smoke. If they don't, do their friends, family smoke? Are they around passive smoking? They inhaling secondhand smoke. What's their occupation? Are they exposed to chemicals or irritants? So now we're going to go back over the questions. And I'm going to whiz through them, but feel free to pause. So question 1, the answer is it causes smooth muscles to relax. Question 2, how is asthma usually diagnosed? Spirometry and reversibility testing. And again, feel free to pause. But what would be common symptoms for an asthma patient? It would be wheezing, shortness of breath, chest tightness and coughing. And that's it, guys. Thank you for listening. And please check out my COPD presentation. Thank you. Bye.